Good morning, good afternoon, good evening. We're broadcasting today from Singapore as well as Paraguay. Victor Canada is behind the scenes today, and I'm Lowell Kabnick. I'll be your uh, host today, and we have a guest host, Kathleen Osvath, today from Albany. And I'm going to turn it right over to Mark Meissner, who's going to talk about Varithena, etc. Mark, floor is yours.
Good morning. Thank you, Lowell. Thank you, Victor. Thank you, Kathleen, for the opportunity to talk with you this morning. I'm going to try to share my screen here. Does that look okay?
Perfect.
Okay. As Lowell said, good morning, afternoon, evening, wherever you are in the world. Today we're going to be talking about Varithena, when to use or not to use. This presentation is largely based on a position paper that was published by the American Vein and Lymphatic Society in Phlebology just a few months ago. So all of the information that we'll be covering will be in there as well. I don't have any disclosures. I think as everyone's familiar with, foam sclerotherapy is a critical tool in the armamentarium of the venous specialist. Sclerosants disrupt the venous endothelium and ultimately lead to sclerosis. However, liquid sclerosants are rapidly diluted and deactivated by blood and are therefore suitable only for small veins. In contrast, foam sclerosants displace rather than mixing with blood, and this prolongs wall contact and increases efficiency. Foam sclerosants are prepared using a variety of sclerosants, gas mixtures in various proportions, and techniques which include the double syringe and Tessari technique, which does cause inconsistency in their performance. In contrast, polidocanol endovenous microfoam, or Varithena, is the only foam sclerosant in the United States approved by the Food and Drug Administration for the treatment of varicose veins, and differs both biologically and clinically from physician-compounded foam, or what we refer to in the next several slides as PCF. Varithena uses an automated proprietary foam-generating canister to produce a virtually nitrogen-free 1% polidocanol foam with a 65 to 35 ratio of oxygen to carbon dioxide. And PEM differs in several respects from physician-compounded foam. Wall contact time is probably the most important determinant of endothelial injury and efficacy, which is determined by both a foam's cohesiveness and its stability. This group used a biomimetic vein model that consisted of a 4 or 10 millimeter PTFE tube perfused with glycerol, and then they recorded videos of plug formation and degradation of the foam, and then calculated the rate of foam degradation by a variety of computational methods. The dwell time, which is a marker of vein wall contact time, is the inverse of the degradation rate they calculated from these videos. And in comparison to physician-compounded foam, using either the double syringe or Tessari technique to generate 1% polidocanol foam, PEM consistently had a longer dwell time than physician-compounded foams, as shown in the graph here on the right side of the screen. So increased dwell time generally should correspond to increased endothelial disruption and increased efficacy. This was furthered in both in vitro and ex vivo biologic models, and PEM has been demonstrated to be more efficacious than physician-compounded foam. Bataro compared PEM with physician-compounded foam prepared either using a double syringe or the Tessari technique, both in an in vitro model that measures endothelial cell adhesion in a human umbilical vein monolayer, and an ex vivo model measuring also endothelial cell disruption in intact human umbilical veins. In the in vitro model, the number of cells remaining intact, the substrate is shown on the right side, and attached to the substrate was the lowest for PEM, regardless of exposure time, which is shown on the x-axis here. The ex vivo model compared the permeability of Evans blue dye, which is a measure of endothelial disruption, after exposure to sclerosants, and again, endothelial disruption was significantly higher for Varithena or PEM, as shown in the brown bar here. And the clinical results support the efficacy of PEM. The VANISH-1 trial randomized 279 patients to placebo or one of 4 different concentrations of PEM. I'll remind you that the commercially available version as Varithena is 1%. And interestingly, the mean baseline diameter of the GSV in this was quite large in some cases, up to 25.9 millimeters with an average of 7.63 millimeters. The primary endpoint was patient-reported symptom improvement as measured by the VB-SYMQ. At 8 weeks, the average VB-SYMQ improved by 5.44 among the patients in the pooled PEM group in comparison to only 2.13 in the placebo group. Duplex response at 8 weeks was defined as the elimination of saphenofemoral junction reflux and/or complete occlusion of the target vein. And for the pooled PEM group, which included the 0.25 and 0.5 concentrations, as well as 2.0%, the rate of occlusion was 74.5% versus 5.4% in the placebo group. However, there was a significant dose response trend, and for the commercially available preparation of 1%, the duplex response was 80.4%. And again, this is the commercially available dose in Varithena. In comparison to placebo, the pooled PEM group also demonstrated significant improvements in physician and patient-assessed appearance of the varicose veins, VCSS, and the veins QOL-SYM. Venous thrombosis occurred in 12.1% of PEM-treated patients. The fate of these thrombi appeared to be clinically benign. All were detected by protocol-required ultrasound. 88% were asymptomatic, and there were no clinically confirmed pulmonary emboli. Among these 27 events, over half were saphenofemoral thrombus extensions. We can talk about this a little bit more in the discussion, perhaps. Accordingly, Varithena was approved by the FDA in 2013 for the treatment of incompetent great saphenous vein, accessory saphenous veins, and visible tributary veins. And since that time, PubMed review that I did about 2 years ago returned 30 papers and 6 clinical trials that had addressed the efficacy of Varithena. And the results of these are fairly consistent. There are no randomized trials that compare thermal ablation with Varithena. There are 4 observational comparisons, and these show a closure rate for PEM of 90 to 94% versus 93 to 100% for thermal ablation, which is comparable, statistically comparable in all except for the second series shown there. Clinical improvement was identical between thermal ablation and PEM at about 90%. And DVT rates, excluding ablation-related thrombus extension, were also identical between the 2 groups. The clinical efficacy of polidocanol endovenous microfoam in comparison to other technologies has more recently been reported in this elegant network meta-analysis that Lowell and his colleagues performed. 13 comparative studies were evaluated that permitted a network comparison of microfoam to endothermal ablation, high ligation and stripping, and physician compounded foam. The primary outcome was venous closure, and PEM was statistically equivalent to thermal ablation, although it was almost 3 times more effective than physician compounded foam, consistent with the in vitro and ex vivo studies that I showed previously. With respect to complications, DVT rates were equivalent between PEM, thermal ablation, surgery, and physician compounded foam. Despite its general equivalence to other ablation technologies, there are some situations where Varithena does have distinct clinical advantages. It does allow concurrent tributary treatment with the same modality at the same setting, which is an advantage, I believe, of PEM. Allows safe treatment of the below-knee great saphenous vein and advanced venous disease. And most importantly, it does allow treatment in patients with challenging anatomy, whether that be tortuosity or intraluminal webs and synechii. Has a very significant role in recurrent varicose veins from either neovascularization or recanalization, as well as a significant role in venous ulceration, as we'll show in the next few slides. This is a systemic review of below-knee recurrence after above-knee treatment by Jose Almeida and his group, and the 1-year risk of recurrent below-knee reflux after treatment of the above-knee saphenous vein was about 7 to 9%, as shown here. The recurrence risk was lower if the below-knee vein was concurrently ablated, about 80% lower. And their conclusion was, although perhaps not necessary in C2, C3 disease, more aggressive treatment is probably warranted in more advanced venous disease. Unfortunately, as we all know, treatment of the below-knee saphenous vein with a lot of techniques is associated with somewhere between a 4 and 7% risk of saphenous nerve injury with thermal ablation, as in this review from Tobias Hirsch. And the risk of saphenous nerve injury is minimized with non-thermal methods, including polidocanol endovenous microfoam. We all know that chronic venous disease is prone to recurrence, and many of these recurrences are best managed with foam sclerotherapy. In a systematic review that included over 1,500 patients that was done by Tom O'Donnell, at 2 years, 20% of patients, independent of technique, developed a clinical recurrence, and about 20% required an operation at 2 years or greater. Outside of technical errors, the two most frequent sources of recurrence were neovascularization at the saphenofemoral junction, which was most common after radiofrequency ablation. And these small channels can oftentimes only be treated with foam sclerotherapy, and we've already demonstrated the efficacy of PEM in comparison to physician-compounded foam. And recanalization, again, most common after RFA. Both of these sources, particularly recanalization, which may have intraluminal webs and some synechia, are oftentimes optimally managed with foam sclerotherapy. Lastly is the case of venous ulceration, and this is a retrospective review by Deek with over 1,000 patients. About 3.5% of these patients had venous ulcers, and ulcer healing within 1 month was dramatically better with Varithena, 69% versus 5% for laser ablation. There were 2 recurrent ulcers in the PEM-treated patients, and the increased efficacy of PEM in this situation likely arises from 2 things. First is allowing treatment of the below-knee great saphenous vein in these patients, and does allow direct treatment of the periulcer venous plexus, which other series have shown treatment of the plexus alone in the short term is probably equivalent to truncal ablation. So PEM certainly has some advantages in the treatment of venous ulcers. There are some situations when other technologies might be better. Allergies to polidocanol are quite rare, and it's kind of hard to find figures for it in the literature, somewhere between 1 in 1,000 to 1 in 100. But they're quite rare, but obviously Varithena should be avoided in these rare cases. Patients with congestive heart failure, congenital heart disease, and other types of central venous hypertension often don't have a great result with foam sclerotherapy, and at least in my anecdotal experience, I haven't had good results in these patients with Varithena either. And although it's clearly effective for the treatment of small saphenous reflux, its use in the US is off-label and may not be reimbursed by some carriers. A few authors have also reported factors that are associated with Varithena failure in this series of 127 limbs with a variety of truncal veins treated at UCLA. The closure rate was 91%, and failure of closure was 11 times more likely in those with a BMI of greater than 30, and was almost 5 times more likely in those with a vein diameter of greater than 10.2. In this series, anticoagulation was not associated with failure of closure, although in another series with longer follow-up out to 104 days, a failure rate of 10.6% below the knee was twice as common in those on oral anticoagulation. So I think that's still a little bit up in the air about the role of anticoagulants and closure failure. So in conclusion, non-compounded foam, or PEM, Varithena, is a safe and effective option for C2 to C6 disease, has several advantages over physician-compounded foam, both in the test tube and in biological models, as well as shown by Lowell, clinically is about 3 times more effective than physician-compounded foam. Its clinical efficacy is equivalent to thermal modalities without the need for tumescence, and it does have some clear advantages over thermal ablation for challenging anatomy, recurrent varicose veins, the below-knee great saphenous vein, and probably venous ulceration. Thank you so much for your attention.
Thank you, Mark. That was wonderful. I'm going to start off the question because Omar Esponda thought one was really good. The thoughts on the use of Varithena for great saphenous vein below the knee and the occasional deep vein sclerosis, (DVT), at the posterior tibial vein or gastrocs. How do you prevent that, and how to manage? Mark, you got any ideas? If not,
Well,
Certainly go on.
prevention, I think, is key in the thorough mapping for perforators before doing the procedure, and then digital compression over the perforators, as well as asking the patient to plantar flex and dorsiflex the foot for about 30 seconds after injection, I think, are the best ways to prevent that. As far as the treatment goes, interestingly, David Wright in the initial Varithena studies measured D-dimer levels in these patients. It was never published. There was concern about it impacting the FDA's approval, so it's never published. But interestingly, these deep vein thrombotic events were not associated statistically with an elevated D-dimer level. And D-dimer is a marker of activated coagulation, which raises the question of whether these should be treated with anticoagulants when there's no activation of coagulation in the first place. And my personal opinion is these calf vein thrombi with no activation of coagulation, I ignore them.
Thank you. Uh, Professor Parsi from Australia did the same thing, published in the Journal of Phlebology, and looked at D-dimers and came up with that most of these are sclerotic.
Right.
And also, he also came up with the idea that none of the maneuvers work to prevent these thrombi or sclerosis. I'm going to turn it over to Kathleen. And the floor is yours, Kathleen.
Thank you so much, Mark. That was great. I was wondering, when do you make a decision to use this versus other, therapies such as glue, for example? Dr. Kiguchi wrote a beautiful paper that I quote sometimes when I give talks about using glue in patients with VLUs. And again, when I first really embarked down that road, I thought to myself, oh my gosh, when you're putting in something like glue into a patient, that stays with them, and is there a risk of infection? So how do you determine what to use? And then Dr. Kiguchi, I'll ask you the same.
So please keep your answers short.
Okay, my short answer is I never use glue ever. And both because that's surgical training of don't put in an implant when you can accomplish the same thing without an implant. And the second is from a vast clinical experience using glue for venous malformations. And oftentimes for venous malformations, it's the only thing that we can treat some of them with. And we always excise the glue afterwards. And just looking at the histology and things, I don't use glue.
Fair enough. How about you, Dr. Kiguchi?
That's a great question. Who chooses is basically my insurance coverage. That's my short answer. But it's actually really interesting. In my practice, it's mostly CEP5 and CEP6 disease, and so I find it very interesting how in patients where I see huge amount of ulcer plexus, I tend to use a lot more of the PEM because I know I'm going to need to treat that. And so if I had all things created equal of insurance coverage, when I see that and when I see these refluxing tributaries and varicosities, I definitely use the PEM.
Masaki, do you have any comments or questions to Mark?
I actually have two, Dr. Meissner. One is, especially in these patients, and this is sort of what was said in the chat by Dr. Esponda, is, I've noticed that in patients with more, we really do treat the below knee saphenous vein, great saphenous vein with whatever modality, especially in patients who've had advanced disease, to decrease recurrence, but also to treat them if they have any additional symptoms. And what I've really noticed is that in these patients, you really have to be a little bit more careful because they do have a lot of these refluxing perforators. And it's interesting when you had all of those percentages of DVTs or ARTs, whether if you had actually separated them between people who have much more advanced disease like C5 and C6, I wonder if because of those advanced disease and the presence of perforators, that those patients actually had more incidence of ARTs than the people who had C2 to maybe C4. So that was just one thing that I wanted to say. But also, I know that there's.
Masaki, do you
Oh,
really
sorry.
think it's art as described? this is a debatable question. So anyway, go ahead. I'm sorry, I had to bring that
Oh,
up.
no. Yeah, no, absolutely. And I also agree about the maneuvers as well. I think it makes me feel better when I see the sclerosant going away when they're pumping their foot, but I truly don't believe it actually does that much. It does still makes me feel a little bit better, but I just find it interesting because I do see in these patients, at least in my observational studies, that they do come back with, even like you said, a little bit more sclerosant scarring in the tibial veins. And I just need to be a little bit maybe more careful about it. But again, that also could just be these patient populations. A lot of these patients don't walk a lot. And that's exactly why that they get these ulcers. And so maybe it's just this patient population that are more susceptible to begin with, but it's just something to consider as well. The
Dr.
one thing,
McLaughlin, go ahead.
my
Quick
second
question.
question, I'm sorry, was I do see that there are observational studies off label about the small saphenous vein. Is there any sort of new studies that are coming down the line, Dr. Meissner, that you know of, whether this will get approved for the small saphenous vein?
Great questions, Ms. Hocking. And in response to your first question, that's a great observation that, these patients with C5, C6, C4 disease do have a lot bit more refluxing perforators and probably are at higher risk. I don't know personally of any study that has stratified it by that, but I think that's a really good observation that you can take home clinically, that those patients are at higher clinical risk. This was a big discussion when the latest guidelines came out, where it was recommended that we no longer screen for ART or DVT, and there was a lot of disagreement about whether you ought to after Varithena, and it made it into the guidelines that we should screen. I personally do not screen for the reasons we talked about. Is if the patient's not symptomatic, if they're asymptomatic and at low risk, and low risk, I mean no previous history of DVT, not obese, fully ambulatory, those things, I don't look for it. And we started that probably 3 or 4 years ago and have not had any clinically relevant DVT show up after that. And
Mark, I'm going to have to switch over to Todd Jones.
okay, sorry, I didn't get the second question.
We'll get to maybe. Todd?
Yes. So Dr. Meissner, I have one question for you. I know what I do in my own practice, but do you have a hard cutoff for vein size when using PEM? There's, I think anecdotally, it's logical that a larger vein that carries more volume is going to be more resistant to something like PEM. Anything there?
If you look at the VANISH-1 and VANISH-2 trials, they included very large veins, up to 2 centimeters. But I do find the data from UCLA pretty compelling, that veins over 10 millimeters do have a higher risk of not closing. And so what I personally do in my practice is, if other things if there's other technology that's amenable, such as thermal ablation, and it's a large caliber vein, I will usually go with that. That being said, there are some situations that we went over, and they're usually not the large caliber veins, but there are some situations like the neovascularization and the recanalization that really any catheter-based ablation does not work well in. So, and admittedly, there's not many of those that have really large veins. They're mostly small veins. But all other things being equal, if it's a very large vein, I will usually go with a thermal technology.
Yeah, and then the other thing I would like to comment on, that Dr. Esponda had already mentioned, and you guys had already kind of asked and answered, but and Dr. Meissner, you said this very well. I think these baloney thrombus extensions just really don't matter. We don't look for them either here unless the patient is particularly symptomatic down there, and even then, that's very hard to differentiate. Well, is that a consequence of this extension, or is that just their response to the therapy and these closed veins? And then when they have C5, C6 disease and it gets into a perforator that was previously refluxing and shuts that down and then extends into the posterior tibials and perineals or something like that, I'm kind of happy about it because I was probably going to have to treat that vein anyways.
Yeah.
And so I consider that a bit of a 2-for-1. And the only time that I've ever treated these is when it's extended up into the pulpiteal for the baloney for my practice. And even then, I've never had a clinically significant embolization or anything like that. So
And I agree with that, Todd. That's exactly what I do. And kind of the whole thing doesn't, unless it's an extending thrombus, it doesn't make a lot of sense. It's sort of like treating a patient with an 80% body surface area burn with anticoagulation rather than Silvadene, because it's a chemical burn.
mhm. Yeah,
I'd like to spend the last few minutes talking about Masaki's last question with the small saphenous vein and why isn't it approved at this point?
Well,
And how could it get it approved?
I know of no ongoing studies. I did note that Boston Scientific for a time was interested in looking at the small saphenous vein in the AVLS provenous registry. That project is not underway at the current time, so I don't know what the feeling at the industry level is about getting the small saphenous vein approved, but clearly I think it is effective. There's plenty of papers out there showing that it is effective and that it is safe. And I do occasionally use it in the small saphenous vein, particularly ones that are very tortuous or recanalized, because I think it's the optimal treatment.
So you wrote a position paper with a group of colleagues. Would you entertain one on the small saphenous?
Yes. And in fact, it was included in the final paragraph of that paper that the expanded indications to include the small saphenous vein should be considered, because I do think it's a good treatment for it.
Masaki, did you have that? Was that your second question? Any other comment? Kathleen, Todd, we can now
I
open.
wholeheartedly agree with Dr. Meissner. I think small saphenous vein it's a great treatment, especially for the right patient. My pet project is actually I've asked the registry at AVLS for the data on SSV Varithena. So,
and I hope you get that, Todd, because I think that'd be a great project.
Here's a quick question. Why are we seeing a lot of thermal above knee and PEM below the knee when you could, in theory, treat the whole saphenous vein with PEM? Why are we seeing that?
I think it's probably variable depending on the practitioner. Certainly, there are some economic incentives for that, but I also think that a lot of people are not necessarily that economically motivated, but they're more comfortable with their results with thermal ablation than they are with PEM. And I would have talked a little bit more about it, but I do think that really strictly adhering to the IFU and the protocol is important for good results. So you can't just shoot it in and hope you're going to get good results. You have to follow the recommendations.
Kathleen, final comment.
One comment, I also treat a lot of patients with sepsis disease, and I found that wrapping them in either a Pro4 or an Uniboot after injection makes a huge difference. Can you guys quick comment on that?
I do think compression is very important, Kathleen, and I do tend to use the eccentric compression in the Varithena packages over the treated veins and then wrap as well. I have not used a Pro4, but I do think compression is very important afterwards.
Same. The one thing I would just say about the chemical or, the PEM is that I'm in a place where people are very organic and really, yes, tumescent also has chemical in it too, but they hear the word chemical ablation and they kind of freak out. And so I actually have had a large chunk of people who go for thermal just because they don't want that sort of extra chemical in them, despite me assuring them it's fine.
Yeah,
Well, thank you very much. I really appreciate everybody being here. Mark, fantastic. All, thank you for all. I wanted to tell you that next week we're talking about phlebectomy, when and why. And we have a guest star, Stefano Ricci, who's written publications on that. Kursat Boskirk will be a discussant, as well as Kirsten Simmons. Thank you, Dr. Kikuchi. Thank you, Dr. Osvath. Thank you, Todd Jones. And thank you, Mark Meissner. Have a good rest of your day.
Thank you, everybody.
Thanks,
Thank you all,
everyone.
Kathleen and Todd.
Bye-bye.
Bye.
Nice to see everyone.